All right, so this morning we want to start the program talking about a Walk of Faith initiative and the improvements to, my apologies, not a Walk of Faith, a Walk the Talk initiative and the improvements to the Accident and Emergency Department at the Eric Williams Medical Sciences Complex. I have with me Mr. Davlin Thomas, who is the Chief Executive Officer of the North Central Regional Health Authority, and I also have Dr. Ravi Lala, who is Head of the Adult Emergency Department and also the Acting Medical Chief of Staff. Good morning, gentlemen.
Good morning.
How are you both this morning?
Great.
All right. Mr. Thomas, I know that you are the Chief Executive Officer of the North Central Regional Health Authority, and I want to say congratulations to you because I know that you were awarded the Paul Harris Fellow by the Rotary Club of St. Augustine.
Yes, thank you.
That was in appreciation of the tangible and significant assistance given for the furtherance and better understanding and friendly relations among the people of the world. I want to say congratulations to you for that. If I'm not mistaken, that award was given to you on the 8th of August.
Yes, it was. Thank you.
I mean, you're here, so tell me a little bit about the award first. Then.
Well, the award, I mean, it was humbling, you know. And when in fact, they invited me at first to do a presentation for them on some of the work the RHA was doing. And the approach that we're taking in terms of governance and what was interesting for us was the sense that the Rotary Club is very interested in getting involved in a lot of the community activities. So the award basically is on behalf of the NCRJ, you know, which is an interesting position to be in.
And I understand it's an award that many outstanding people around the world have gotten as well. So for you to be able to get that, I mean, it must feel amazing.
Yeah, it's humbling. It is humbling. You know, I want to say thanks again to the Rotary Club for bestowing the award.
Yeah. And well, hopefully you get many more awards. And hopefully I might get some too. Hopefully they're looking on this morning and they're saying, you know, he's a good young man. We can probably, you know.
Yes.
Thank you, Mr. Thomas. Well, I want to get into the conversation now to talk about Walk the Talk.
Yes.
What is Walk the Talk all about?
It's interesting that you started with a walk of faith, because when we started, well, the first issue is that we're taking a totally different approach to how we deliver healthcare. On the ministers this NCD plan, I don't know if you're aware of it.
Yes, non-communicable disease.
Yes, yeah. And the real objective is to engage NCDs and mitigate against the proliferation, because 86% of the people who die in Trinidad and Tobago die from one of those diseases related to NCDs. It was important to the NCRHA that our approach isn't simply dealing with those patients who come into the emergency department at the tail end along the continuum of the diseases. So we wanted to get at the earlier stages where we could prevent those problems that start to occur, and by extension to mitigate against some of the costs. And we're seeing cost reduction already. So what we decided was that we were going into churches, temples, and mosques with the blessings of the minister and the board to engage those persons and do preventative medicals. When we went into the first, and with a prototype, so the first time we went in with doctors, nurses, dietitians, etc. And we went to Curep Presbyterian Church, good morning. And when we got there, what happened was that there was this little boy, and the cleaner just said, the person who cleaned the church, she said, you know, he's having a little belly pain. And this, we were seeing at least 50 to 80 persons, because it was the first prototype. Now we see about 100 to 200 persons in one day. And when we got, she came and she said, you know, he's having a little pain. When we checked, it was appendicitis. When we got him to the emergency department, the appendix ruptured. So had we not been there, that child would have died. And immediately we knew we were on the right track. So we've replicated that. We've seen within the last year 11,000 persons.
That's a huge number.
11,000 persons, full medicals, including 7,000 vaccinations. So we're really enjoying saving the lives. With a 64%, and Ravi, Dr. Lala will elaborate on that. But we're seeing 64% reduction in the emergency department, in the congestion in the emergency department. We used to have over 160 to 200 persons at any given time. We're down to between 80 and 110. But again, it's from an approach that engages the communities. So the walk the talk really is an overarching system of an approach that engages community. Last weekend, and well, again, we went into Blanche Shares, and Dr. Lala will elaborate on that. But we're taking an approach where we're going into communities. We have an in touch. Once you start to revolve in our emergency department and return, we go to your house. We're looking for the conditions at your home that create the situation that brings you to us. And it might be simple that you may not be taking your medication and so on. But Walk the Talk basically provides that intervention within the community to facilitate the preventative medicals that will ensure that you don't deteriorate to a point where you have to come into the emergency department.
And I see Dr. Lala smiling when you said there's a 64% reduction in the number of people that would go to the accident and emergency department.
Oh yeah, I mean, we're very excited about that. It doesn't just mean, of course, less people in the department. I mean, what we're looking at is people actually not having to seek care. And it's what Mr. Thomas saying. A lot of the people who come in, they're coming in because their chronic illness has then decompensated and has led them to come into the department. And it is actually, as you mentioned, the In Touch. We actually had a meeting yesterday about In Touch, and we're expanding that now to include heart failure patients. So again, when somebody comes into the hospital and they're coming with cardiac failure, we identify them on the day you come in. We have liaison nurses going to meet you on the ward, and then they're going to follow you home and check you 2-3 times a week to make sure that
so you get house calls, like house visits from
house calls.
Yeah. In addition to that, we've coupled that with another, what we call the CPCC, which is a cardiac primary care clinic. So within our health centers, we have cardiac clinics, so that a lot of the congestion that happened in the cardiology clinics now overflow into the communities, now are transferred into the community. So we don't have that congestion, but we have the care happening closer to the patients.
Okay. But what, and you mentioned a lot of people are coming out, because in a 1 year since the program started, you all have seen about 11,000 people. So
but we're not waiting. We do not wait on them to come out, you know. What we do is we go on the day that you have your service. So if you have temple on a Tuesday, but basically it's usually on Sundays, we show up. So after you have your service, while you're having your service, we set up, and as you know, churches, temples, mosques have the infrastructure inherently to deal with crowds, the toilets, etc., the spaces that are divided and so on. So when you finish your service, we see your entire congregation. We do medicals for your entire congregation, and that. So we do not have that added dilemma anymore of attempting to find the persons. But what's more about churches, temples, mosques is that they have pastors, priests, pundits, and imams. And so that what happens is the reinforcement, because a lot of the NCDs require lifestyle changes. So for example, if Sister Alberta is diabetic, and we find out that she's diabetic, and Pastor John tells the entire church, don't give her cake. You know, eat cake again. Yeah. And so the reinforcement, the follow-up with your peers and so on is what provides that. And we've taken that to another level. We've provided the churches, temples, mosques with some training, as well as we've given them some of the sugar testing equipment, blood pressure testing equipment. We're logging them, we're following up at the facilities to ensure that they follow their congregations to ensure that they are exhibiting good health and utilizing good practices.
Monitor them. But what types of tests are done at these temples and mosques and churches?
Well, those would be more, as Mr. Thomas saying, would be like a general medical. We'd do your complete blood count, we'd do your liver function test, your kidney function test. I believe we also do eyes, we do some ophthalmology. Yeah.
And basically,
you get a physical exam.
by a doctor.
Okay. Good. So
Dietitian is there. And by ophthalmology, we mean looking for glaucoma and cataracts and so on. And Dr. Lala will tell you about the relationship between that and what we call now our cataract Sundays.
cataract Sundays.
Yeah. So in order to deal with the large amount of people in Trinidad who have cataracts, what we actually do is we have initiatives where on actually this Sunday we have people coming in and we have the entire team. We have the surgeons, we have the nurses, we have food, and they come in and getting their cataract surgery. And that's in addition to the regular lists that happening during the week, because we just want to try and provide care for as much people as possible and get in there quickly as possible, get people back to their regular life.
And imagine in the public system, that you could come in 1 week and within 2 weeks you've had cataract surgery. I mean, there aren't many countries in the world that boast of that. And the minister would have said that, and I just want to segue and leapfrog to the fact that we've had no maternal deaths for the year.
The minister has repeatedly said that because it's an accomplishment.
But we're also having a decline in stillbirths over the last 3 years, a 28% decline. So we're really, really focused and excited about not just delivering healthcare, but engaging in a process that makes people well and take responsibility that you don't access the healthcare system, that you are part of the healthcare system, and that is critical to the NCRHA and the minister and the board.
This program that we're talking about, the Walk the Talk initiative,
right?
How long is that going to go on for again?
Ever.
So it's a real long-term initiative.
Yeah. Because and what we expect that will happen is that it will evolve and change. Because once we get past those basic and people are in control, it will evolve to other kinds of interventions that are required. So for us, the issue isn't just the universal healthcare in terms of the availability of the healthcare. The question for us is how do we create a situation where people access that care with the greatest of ease.
Yeah. Because people are always complaining about our health institutions and saying when they go they have to wait long hours, sometimes they don't get a bed for hours overnight, they have to sleep on the ground and a lot of things. Have you seen a decline in that since this initiative has started? Have you heard less complaints about these things? Or is it that...
we've had marginally less complaints because people complain about the time they spend in the hospital, and Dr. Lala will elaborate. But when you look at the standards, the international standards, people, when you go into the US or the UK and you go into a hospital, depending on the nature of your illness, you will spend 24 hours in the emergency department. With us, it's less than that. You spend between 2 to about 8 hours.
Yeah. Most times you will not cross 10 hours. And when we say 10 hours, we're speaking about people who have low acuity problems. The way how the hospital set up is that we will end up seeing the people who have the more critical illnesses first. Now, there's a dynamic process. So if on day 1 there are 10 critically ill people, and then on day 2 there are 20 critically ill people, obviously the waiting time for the less critically ill people will be longer. And that's the nature of emergency.
But what we've managed to do, as I should mention, Rishi, is that those 4 and 5, we have 5 levels.
Yeah. 4
and
5 is low.
Levels 4 and 5 now, we've created an assembly line for those patients. So the ones who tend to wait now are the level 3s, which are in the middle. but the 4s and 5s, we pass them very quickly. The ones who have the small problems, we pass them through that assembly line. There's a doctor in specific rooms waiting for them. They go in, deal with them, and then they
tend to
can
have two
go.
actually. Two doctors.
Two doctors.
Yeah, doing that.
And people become abusive when they're not getting their way. And we've seen videos on social media all the time. You know, people complaining, they're not getting this, they have to wait. How do doctors feel seeing these things? Do they complain to you? What do they say?
Oh, no, Dr. Lala has put an intervention to ensure that no one...
Dr. Lala, what have you done?
Oh, we have an officer who moves through our department continuously, constantly reassessing people. Those who waiting to be seen, those who already admitted, waiting to go up to our ward, etc. We communicate with people. I mean, you know, they will always have people who are upset, but what we always talk about is the fact that the person who coming in, they're not having a good day. You're understandably upset from the minute you hit the door. You're having a bad day.
All right, I just want to switch gears a little bit now, and let's talk about the improvements at the Accident and Emergency Department at the Eric Williams Medical Sciences Complex.
Yeah, so one of the things, from what Mr. Thomas was talking about, going out into the community, one of the things we did is we moved the emergency department from the boundaries of the hospital. So we have this, our community partnership first response program, which follows on the heels of all these initiatives like Sunreach and whatnot, where we go out into the community. We went out into Blanchie Shares and we taught first response, we taught CPR, and actually at the first, we've done it twice so far since its inception, and the first time we did it, actually, a group of people who went, young people, teens, Soraya and her friends, they saved someone from drowning based on that one course that we created for them. Yeah. And so we did it again, and we continued to do it. And what's amazing about that is there were some young kids there. Jordan, who is 10, came to that. And then, well, further in, back into the department, as I said, we have the clinical officer who moving through. So there's a staff initiative that we have more consultants, so we're providing longer hours of care, more days. We have a high sensitivity troponin machine, and that we're really excited about, because before it would take about 12 hours if somebody come in with chest pain to say, well, okay, you safe to go home. Now, within as little as 1 hour, you could make a decision to send someone home, and safer than you were before, because now we could say with reasonable certainty that your chance of having a major adverse cardiac event is less than 1% in the next 30 days. And we continue to innovate there with not just the machine and that safety, but also now with new protocols that we're generating. So
there's a lot of work that you all are doing to try to help and make the process a bit easier for people.
Yeah.
Yeah, and not just easier. Yeah, the issue is that you are ill. And one of the things and that's why we keep saying to people that you didn't approach the healthcare system. You belong to the healthcare system. So
people don't feel that way though.
Well, exactly. Well, inherently they should, because if you smoke, eat what you want, do not exercise, then you will end up in the emergency department. And so that the inverse is absolutely important to acknowledge. That if you take care of your health, then you decrease the congestion, so that inherently you are, so that your idea of how you feel about the healthcare quote unquote system really is erroneous. That people ought to understand immediately that you need to take care of yourselves, and that's critical to what we are doing. We're engaging the communities to maintain lifestyles that change the dynamic. We have a program called Life Like a Boss. I want to say good morning to Ms. Gurdine. Miss Gurdine is our Like a Boss patient. Ms. Gurdine had diabetes, and then she reversed the diabetes. She reversed it, and she followed our plans, etc. Is doing exercise and so on. And she's in a position now where she's living a healthy life. And so we celebrated that. The minister came in, the board came in, and we gave her a hamper. We celebrate her. When she comes into clinic, we ensure that she has security and she does not wait because she's taking care of her health like a boss.
So if you take care of your health, it makes it easier for yourself, and it also becomes easier for the medical practitioners, to your point.
Oh, yeah.
What about the accident and emergency department for the children's ward at the hospital?
Yes, superb. I mean, that's as well a premium service. What's happening is that when you go into that department, you within 20 minutes, if you don't have a critical emergency or a crash, you're seen by pediatricians, highly trained, and it's better than, in fact, both the adult and the if you are very ill, you should show up at the emergency department at a major hospital, because that is where the premium service is. If you have, so for example, that's where you get your CAT scans, MRI, and so on. If it's absolutely necessary, you get it immediately, you know. And that is not that is not old talk. That if you require premium healthcare services, the highest level radiological services, and so on, immediately by the Eric Williams Medical Sciences Complex, the San Fernando General Hospital, etc. That's where you get it, you know, and Port of Spain, that is where you access that care, you know. And we're very proud of it. It's something that the minister advocated when he came into office, because most of the CEOs are new, and one of the interesting things is that we had a high level of downtime for major equipment. But you don't hear about that anymore. We're in a situation where our uptime is 98%, and that 2% is when we decide to take it down to either upgrade or to do maintenance works.
But then why do people complain so much?
Well, that's a riddle for us, you know. There's a guy called Rory Sutherland who says, you know, and which is why we're out here, that sometimes when the reality has changed, sometimes the perception takes a little longer to drift. And so we're here to spread the gospel of change, that it has occurred, and that, you know, it is occurring. But when you see 11,000 persons in the community, even though the folklore, and that's why we caution, we like to caution the media people that we meet, that sometimes your perception, and you say, well, you know, people complain, but when we see 11,000 people in our community and give them medicals, and we have other medicals going, the Brothers Keeper, where we see another 5,000, we ready for the road, where we do executive medicals for another 5,000. Those 25,000 persons are speaking positively about, we just had, for all the persons who are going to Hajj, we just did complete medicals for all of them, and they had an exceptional time, you know, and they were vocal about it. They were open and vocal about it. So I mean, yeah, so our job now is really to just spread the message about the care that we're providing.
Yeah. Yeah. Dr. Lala, I want to get your final remark.
Well, I wanna thank the Minister of Health. I want to thank the CEO for really being able to have the vision and allow us to continue to vision and move forward.
Mr. Thomas.
Yeah, I just again want to remind that the healthcare system is not a separate entity. It's that permeating that are the people within the country or within the purview of the NCRHA who have to engage in their own personal well-being, you know, and we will support you.
And
Yeah.
you know, the Minister of Health did say that some Cuban doctors and all are coming in, so that could probably assist with some training and that kind of thing for you.
Yeah, and
wherever
particularly
necessary.
some of the specialist doctors are coming, you know, and we really look forward to that, to include them in our programs.
All right, Dr. Ravi Lala, Head of the Adult Emergency Department and the Acting Medical Chief of Staff, and Mr. Davlin Thomas, the Chief Executive Officer of the North Central Regional Health Authority. Gentlemen, Thank you both for coming in and talking with us this morning about Walk the Talk and also some of the improvements at the Accident and Emergency Department at the Eric Williams Medical Sciences Complex.
Thanks for having us.
This is Good Morning Trinidad and Tobago. We take a break and come back with more.